These are my disclosures. We'll start with the case. This is an 83-year-old male who underwent surgery for fracture neck femur. Second day post-op developed inguinal retrosternal discomfort at rest. ECG showed an inferior wall STEMI. And he reached our hospital about 36 hours post-op. This was his blood pressure, saturation of 88, and a little bit of pulmonary edema. He was in CLIPS class 3. This is what his ECG showed us, and the echo showed inferior posterior lateral wall to be hypokinetic. Severe eccentric MR, but no papillary muscle rupture. EF was about 40%, but he had severe PAH and was extremely uncomfortable. Thrombolysis was out. We took him up for a coronary angiogram after a high-risk consent. He had peripheral vascular disease, right radial and feeble left femoral, so we had just one axis, and this is what his angiogram was like. You can see that it's a large dominant circumflex that's occluded. There's also significant disease in the proximal LAD. So these were the options, but because of his age, his post-op status, and his frailty, we decided to go ahead with the primary PCI. The wire was crossed, the balloon was inflated, dotted, little bit of residual thrombus, quite significant with TIMI2 flow. We went ahead and did a thrombosuction, and that's what we got. This was our result on that day, and this is the topic of my talk. What do we do now? It's just an opening gambit for the whole message. Acute myocardial infarction is one of the largest killers in the world today, accounts for 1.8 million deaths in Europe. The age standardized death rate is 235 per 100,000 worldwide, but in India it is even more scary, 272 per 100,000. And deaths before 70 attributable to cardiovascular causes are 23% in the Western world, but are above 50% in India. This is a massive problem for us. Primary PCI is the gold standard for reperfusion, and we are able to open 95% of occluded arteries by primary PCI. The infarct size early decides what the mortality, the heart failure, and arrhythmia burden is going to be in that group of patients. And the infarct size at 1 month decides mortality and heart failure hospitalization at 1 year. These are hard facts that we know. Early reperfusion is the key. But up to 50% of the infarct size that we see is due to tissue damage in the myocardial tissue and microvasculature that's caused by the reperfusion injury. To put it in a graphical term, if one looks at this graph, on the left side you see the size of the infarct, the theoretical infarct, how large it would be if the artery was not opened at all. And on the left lower side is the ischemic time and the reperfusion time. Although we are able to minimize, even if we're able to cut down the reperfusion time, the magnitude of the infarct is larger than what we would expect it to be if all our reperfusion was successful. And the difference in these two is basically the amount of infarct that is attributable to the reperfusion injury. This is another slide which shows you the same thing, that the size of the injury is basically contributed to by ischemia, that is mediated by mitochondrial depolarization, ATP depletion, sodium and calcium overload, acidosis, reactive oxygen species, and secondarily due to reperfusion. When we open the vessel, you have calcium overload, pH correction very rapidly, reactive oxygen species, MPTP opening, mitochondrial dysfunction, hypercontracture, and this ends up in lethal reperfusion injury. And the topic of my talk is to see what we can do to stop this or prevent this part of our injury. Now, the reperfusion injury has got basically two mechanisms. One part is due to the cardiomyocyte compartment damage, and the second part is the coronary vascular compartment. In the myocyte damage, we have sarcolemmal rupture, calcium overload, MPTP opening, which were actually closed prior to opening of the vessel, and apoptosis. And on the coronary vascular compartment, we have microembolization, impaired vasomotion, edema, capillary obstruction, leukocyte adherence, and capillary rupture. Both these together lead to irreversible injury, and it's actually very difficult to decide which part is because of what. There's probably an element of both in the total magnitude of reperfusion injury that we do have in this subset. The other clinical elements that decide the magnitude of defect is the size of the area at risk, the duration of occlusion, collateral blood flow, microvascular dysfunction, lethal reperfusion injury, extracellular vesicles or exosomes, among which there is furious research because these are small extracellular vesicles which contain active molecules which actually mediate some of the damage which takes place after we reopen the vessel. The lethal reperfusion injury is contributed to by oxidative stress, the calcium overload within the cell and within the mitochondria, the rapid restoration of physiological pH with increasing cellular edema, The MPTP pore, which was actually closed, opens and thus leads to mitochondrial death, ATP depletion, and cell death. Now, the protective strategies, which is what have been looked at so far in the rest of the world, can be divided broadly into three groups: the ischemic conditioning trials, the pharmacotherapy trials, and the physical intervention trials. Now, ischemic conditioning could be preconditioning or post-conditioning, and since the patient has already come to us with an occluded vessel, it's only post-conditioning that we really looked at. This is alternating balloon inflation and deflation immediately after opening the culprit artery. It was shown to be protective in multiple phase 2 trials and animal studies, and with a lot of excitement, lots of large studies were designed, and small studies in phase 2 trials were actually quite encouraging. The mechanism is changes in the pH, changes in the nitric oxide synthesis, subsequent generation of ROS and nitrogen species, increased reperfusion, injury, salvage kinase. This is a protein whose level could be measured in tissue and which actually told us how much damage was taking place. But in Dynamite 3, which was the largest trial which looked at this in a randomized fashion, 1,234 patients within 12 hours for STEMI, with STEMI 0 or STEMI 1 flow, routine post-conditioning during a primary PCI failed to reduce the composite outcome. It's possibly because the post-conditioning was done too late, and the authors actually said that ideally post-conditioning should be done within 15 seconds of opening, and in that trial it was out to nearly a minute, a couple of minutes, or 3 minutes. And so it didn't really work. Remote ischemic conditioning is a set of serial inflations and deflations with a pneumatic cuff on the arm or the thigh to induce brief cycles of ischemia and reperfusion. Again, this was shown in phase 2 trials and animal studies to decrease infarct size by 20 to 30%. However, the Condi-2 ERIC primary PCI trial in 2019 that looked at 5,401 patients with STEMI, this failed to show improved clinical outcomes. There was no difference in cardiac death, hospitalization, or heart failure at 12 months. Infarct size was not reliably measured between the two groups, but there was absolutely no difference in clinical outcomes, which we know are actually a surrogate of the size of the infarct. Possible reasons for failure were that animal models used for IRI do not adequately represent a typical STEMI patient, because you know exactly when the artery is occluded in an animal model, but we are guessing at it in a patient with a primary PCI. It's possible that the remote ischemic conditioning limb protocol was not sufficiently optimized, that we need longer and more robust occlusion of blood flow to the limbs before it actually becomes protective, and the presence of comorbidities that probably confound the results. Now, there is also some pharmacotherapy that's been used: exenatide, nitric oxide, cyclosporine, MTP-131, adenosine, and sodium thiosulfate. Exenatide is a GLP-1 receptor antagonist that inhibits apoptosis and decreases oxidative stress. It's been shown to significantly reduce infarct size and increase the myocardial salvage index in animal models and small clinical trials, but it is the subject of furious research right now, and probably next year's TCT will see our first moderate size results from this trial. Nitric oxide has been shown to decrease infarct size with enzyme release, and CMRI, both showing decreased infarct size. This also awaits further studies, although it's a little cumbersome to actually deliver the nitric oxide into the coronary, but still it remains a target for further research. Cyclosporine has been tried, but there's no clinical benefit, no difference in CK, troponin, or adverse LV remodeling at 1 year. MTP-131, which targets mitochondria, was also studied in a phase 2 trial, and it hasn't shown much of a difference reported in 2016-17. Adenosine has been the subject of multiple large trials, 13 RCTs to be exact, 8 of them using intracoronary and 5 of them using intravenous. The meta-analysis showed a significantly lower incidence of heart failure and slightly lower no reflow amongst the group that used adenosine, but there was no difference in non-fatal MI or all-cause mortality, which is what we're looking for actually. Metoprolol has also been subjected to furious research, and it's been shown that when you do it 90 minutes after coronary occlusion, it reduces MI size and improves LV systolic function. But when one uses it beyond 30 to 50 minutes after that, that means beyond 120 minutes, there's no difference. So this probably protects against ischemic insult rather than the reperfusion insult, and so it's pretty much out as far as protection from reperfusion injury is concerned. Sodium thiosulfate is again another molecule that is being tested presently, and this is shown in rat hearts to have a reduced infarct size. The IV-STS is currently undergoing a phase 2 trial that will be reported sometime in 2024. Physical intervention, therapeutic hyperoxemia and hypothermia, both have been tried, but the AMI-HOT trials didn't show any difference nor in the intracoronary heart trial in 2019. There was enough evidence for a larger randomized study, but it's not really as big as we thought it would be. Therapeutic hypothermia actually increased AF and cardiogenic shock in the hypothermia group. So this has also pretty much been left alone. In summary, because of poor animal models and study designs that didn't use infarct sizes to measure the difference in the two groups, dosing intervention protocols, which are always subject to change and are actually quite arbitrary because we don't know the routes and timing of administration also, which need to be more precise and more exact. There's a lot of promise, but no proof of efficacy. It's a continuing journey with an attractive target, the pot of gold at the end of the rainbow, and I'm sure we're going to continue to look for this particular pot of gold in some time. What happened to our patient? This is what we did. His ST resolved, and we kept him on intracoronary adenosine for some time, and then on day 5 post-op fixed both his circumflex and LAD. That's our final result. That was his echo. Thank you very much for your attention, and I should be glad to answer any questions.